Ocular and orbital tumors. First, we'll discuss about retinoblastoma. Retinoblastoma, also known as glioma retina, it is the most common cause of intraocular tumors in childhood, with incidence of about 1 in 20,000 live births. After malignant, first one is malignant melanoma of choroid. This is the second most common malignant tumor. Second most common malignant intraocular tumor. There is no sex predilection, usually seen between 1 to 2 years, and it is very rare beyond 6 years. Rarely beyond 6 years. It is common in whites than Negroes, and 25 to 30% of the cases are bilateral. It is there is RB gene located on chromosome 13q14, which is a tumor suppressor gene. This is a tumor suppressor gene. It is deletion or activation of this gene by two mutations known as it is known as 2-hits hypothesis. It results in the formation of retinoblastoma. Then of all cases, 10% are familial. 10% of the cases are familial and 90% are sporadic. After sporadic cases, 2/3 occurs by somatic mutation and 1/3 by germline mutations. Then if there is bilateral retinoblastoma plus pinealoblastoma, then it is known as trilateral retinoblastoma, which occurs in 10% of the patients. Plus bilateral retinoblastoma is known as pinealoblastoma plus bilateral retinoblastoma is known as trilateral retinoblastoma. Osteomas of bone and soft tissues are commonly associated tumors. These are associated tumors. Okay. Now, on histopathological examination of retinoblastoma, these forms can be seen, that is the flexner intestinal rosettes. These are highly specific. This is the flexner intestinal rosette. Here a single round of cells with an empty lumen. The lumen here is empty. Whereas in next is the homorite rosettes, flexner intestinal rosettes and homorite rosettes can be seen. In homorite rosette, there we can see a ring of cells with an eosinophilic fibrillar. These fibrillar centers can be seen here. In flexner intestine, the lumen is empty, and in homorite we can see this eosinophilic fibrillar center. Now the patient presents, most common presentation is leukocoria, that is white pupillary reflex or emerotic cat's eye appearance. This is the most common feature that is in present in about 60% of the patient. Squint is the second most common feature. Squint, second most common feature. Then other features include nystagmus, defective vision. Others include nystagmus, decreased vision, defective vision, proptosis, or painful red eye due to secondary glaucoma. Now this glaucoma can either be due to pushing of the lens iris diaphragm forward. It can be either be pushed forward, and glaucoma can be due to that, or because of the tumor cells clogging the trabecular meshwork. It can be either because of the iris lens diaphragm pushing of the, it is either because of the pushing of the lens iris diaphragm forward or tumor cells clogging the trabecular meshwork. Now this retinoblastoma can be of two types. It can be endophytic or exophytic. The endophytic grows into the vitreous cavity. Endophytic goes into the vitreous cavity. If there is calcification, then it is known as cottage cheese. It is known as cottage cheese appearance. There is calcification. Okay. Two types, endophytic and exophytic. Now in exophytic, it grows outward and separates the retina from choroid. Here, this exophytic growth, it separates the retina and the choroid, and this can give appearance of exudative RD. In endophytic, it grows towards the vitreous, and if there is calcification in endophytic growth, it is known as cottage cheese appearance. Metastasis first occurs to the preauricular lymph nodes. First metastasis. Okay. Direct extensions occurs by continuity to the optic nerve. This is by a direct extension. Direct extension occurs by this, and metastasis occur to the through the preauricular lymph node. Direct extension occurs by continuity to the optic nerve, which is affected early. Calcification of the tumor is very common. Optic nerve direct extension. Now, treatment is based on the international classification of retinoblastoma. This is international classification. It is divided into group A, B, C, D and E. In group A, it is less than 3 millimeter. And the tumor is away from the optic disc. It is less than 3 millimeter and away from the optic disc. And in group B, it is more than 3 mm. More than 3 mm tumor will be there, and in group C, it is there will be subretinal fluid or vitreous seeding, that is confined. There is a local seeding will be there, confined within the tumor. There will be vitreous seeds, that is tumor cells in the vitreous. In group D, there will be extensive, more than 3 mm of the diffuse seeding will be present, and in group E, there will be more than 50% of the globe will be involved. This is the international classification of retinoblastoma, ICRB classification. This classification is used for treatment. Now, according to this classification, those in group A, we give cryotherapy or laser, focal cryotherapy or laser. In group B, chemotherapy. B, C and D, we give chemotherapies, and E, it is unsalvageable eye, so we give we have to do enucleation. Here, once again I will tell you, this group A, which is less than 3 mm, situated away from the optic disc, cryo or focal laser therapy can be given. Then BCD, that is more than 3 mm or local seeding or diffuse seeding, we give chemotherapy. And in E, unsalvageable eye, we have to do, there is risk of metastasis, so we have to do enucleation. Now, chemotherapy we usually give VEC, that is vincristine, etoposide and carboplatin. Then if there is orbital or intracranial extension or metastasis, then we give then palliative therapy is preferred. Now, to predict the survival of the eye, not the patient, okay, this is to predict the survival of the eye. To predict the survival of eye, not patient, the eye, we use a Rees-Ellsworth classification. Ellsworth classification for retinoblastoma. This is for the survival. According to this, if it is, this is the limbus, about 3.5 to 4 mm from the limbus is the ora serrata, and about 14 to 15 mm from the limbus is the equator where the vortex winds drains. So here if the tumor is solitary and less than 4 disc diameter at or behind the equator, then it is very favorable. If it is 4 to 10, then it is favorable. If it is more than 10, then it is possible. Prognosis for maintenance of sight, it is possible. Then if it is anterior to ora serrata, it is unfavorable, and more than half of retina with vitreous seeding is there, then it is highly unfavorable. So it is like less than 4 to 10, more than 10, that will be very favorable and possible. If it is anterior to the ora serrata, it is unfavorable, and this highly unfavorable if it is more than half of the retina is involved and vitreous seeding is there. This is Rees-Ellsworth classification for retinoblastoma to predict the survival of the eye. Next is other differential diagnosis for like other condition presenting with similar signs in children, that is leukocoria, toxocaria infection, then Norris disease, persistent hypoplastic primary vitreous, retrolateral fibrous fibroplasia, then other cause of inflammatory deposits. In vitreous, following plastic cyclitis or choroiditis. These are the other differential diagnoses for leukocoria. Now, to differentiate leukocoria from these causes from the retinoblastoma, because there are like some specific features of retinoblastoma, like the IOP will be raised and there will be calcification. Here in ultrasound we can see calcification. These calcium deposits can be seen. These are the calcifications which will be seen in retinoblastoma. Then in aqueous humor there will be increased level of LDH, and B scan there will be a cauliflower like mass, and in A scan there is characteristic VY pattern. In pseudoglioma, in these cases, in other cases pseudoglioma, these other causes of other condition presenting with similar signs in children are known as pseudoglioma. These conditions the IOP will be lowered and calcification will be rare and LDH will not be raised. Now coming to other tumors, next is malignant melanoma of the choroid. This is the malignant melanoma of the choroid. This is the most common primary intraocular tumor of adults. Usually presents in the age group of 40 to 60 years. It is always primary, single and unilateral. This is a picture of malignant melanoma of choroid here. Malignant melanoma of choroid can be seen. If it is a spindle cell melanoma, then it has a best prognosis. If it is epithelial cell melanoma, then worse prognosis. Spindle cell and epithelial cell is a spindle cell best prognosis, epithelial cell worse prognosis. So if it is centrally located tumor, then the vision is affected early. In peripheral tumors, usually retinal detachment can be seen. In peripheral tumors causes retinal detachment before the patient becomes symptomatic. Lymphatic metastasis is usually unknown, and blood-borne metastasis occurs to liver. This is the commonest cause of death. FFA, we will see a double circulation. This is a double circulation characteristic of choroidal melanoma, that is with an increase, that is both the fundus, this retinal vessels and the mass will be fluorescent at the same time. This will be, both are hyperfluorescence at the same time. That is double circulation is seen in malignant melanoma. Next is rhabdomyosarcoma. Rhabdomyosarcoma is the most common primary orbital tumor among children. Most common primary orbital tumor. It usually occurs below the age of 15 years. In 90% of the patients, it will usually occurs below the age of 15 years. It classically presents as this rapidly progressive proptosis of sudden onset of a child of 7 to 8 years. This is a classical presentation, rapidly progressing proptosis. The massive proptosis is usually present in the superior nasal. Usually it is in the superior nasal quadrant. So it mimics this acute inflammatory process. Looks like acute inflammatory process. Then in X-ray, CT scan, if you see CT scan, in X-ray there will be bone destruction. In X-rays there will be bone destruction. And CT scan can shows tumor in relation to the extraocular muscle. Here we can see the tumor. Then the treatment is high dose radiation therapy. High dose radiation therapy plus systemic chemotherapy. This is radiation therapy is usually 5,000 rads in 5 weeks. Now chemotherapy regimen usually consists of vincristine, actinomycin D and cyclophosphamide. Excideration will be required if in few unresponsive patients. Eventually we will have to go for excideration if the patient is unresponsive. That is rhabdomyosarcoma. Next is optic nerve glioma. Optic nerve glioma. Now it is a benign tumor that arises from the astrocytes. It arises from the astrocytes. It usually occurs in first decade of life, usually between the age of 4 to 8 years. It may present as either as a solitary tumor or it may be associated with neurofibromatosis. Then the patient will have a early loss of vision. Visual loss will be early, and it will be associated with a gradual painless unilateral axial proptosis. Here you can see it is unilateral. Since it is situated behind the eye, it is like the optic nerve is involved. It is axial proptosis. Unilateral axial proptosis will be there. Then fundus examination may show, because of the compression, the patient might have optic atrophy or papilledema depending upon the duration, and venous engorgement can be seen. The intracranial extension of the glioma through optic canal is not uncommon, and treatment is excision of the tumor, mass with preservation of the eyeball by lateral orbitotomy. In inoperable cases, we can do radiotherapy. Next is optic nerve sheath meningioma. Optic nerve sheath meningioma, it 2/3 of all the meningiomas affecting the optic nerve arise from extension of the primary intracranial lesions. Usually these are from intracranial lesions. These are extensions from the intracranial lesions. Most of them, most commonly. Primary optic nerve sheath meningeal, it usually typically affects the middle-aged women, elderly patients. There is this typical classic Hoyt-Spencer triad where the patient will have progressive visual loss, optic atrophy and optociliary shunts. These are the optociliary shunts. Because of retinal ischemia, in order to preserve the retinal circulation, there will be development, there will be anastomosis between the choroidal and retinal circulation, known as the optociliary shunt. So this is a Hoyt-Spencer triad: progressive visual loss, optic atrophy and optociliary shunts will be developed. There will be in optic nerve sheath meningioma, there will be restricted motility defects, particularly in upgaze, and proptosis also will be there. Now, differentiating between optic nerve meningioma and glioma is usually seen in children. We already see glioma is arising from the astrocytes. So, it is usually seen in children less than 10 years. Optic nerve meningioma is usually seen in middle-aged females. Meningioma is unilateral, glioma is bilateral. Here this arises from the astrocytes, glioma. Meningioma here it can be seen optic nerve, since it arises from the meninges, it the optic nerve is seen separately from the lesion. In axial we can see this tram track appearance. This is a optic nerve, and then the enhancement can be of the tumor can be seen, known as the tram track sign, and in coronal section we can see the donut sign. This is characteristic of optic nerve meningioma. And also there will be calcification, and there is no cystic areas. In optic nerve glioma, cystic areas can be there. This is the difference, basic difference between optic nerve meningioma and glioma. Next is phacomatosis and neurocutaneous syndromes. These are usually autosomal dominant transmission, like neoplasm of the eye, skin and CNS can be seen. Then their first one will angiomatosis retinae and von Hippel-Lindau syndrome. Here the characteristic is retinal capillary hemangioma. It might look like this. The retinal capillary hemangiomas can be seen. In tuberous sclerosis or Bonville disease, we can see multiple retinal astrocytomas. These are the astrocytomas. This is seen in tuberous sclerosis, Bonville disease. Now in neurofibromatosis 1, there is neurofibromatosis 1, also known as the von Recklinghausen's disease. Here we can see neurofibromas of the lids, iris, retina and choroid. Neurofibromas. Least nodules, that is a hamartomas. Least nodule is hamartoma of iris. Can also be seen in case of neurofibromatosis 1. These are the least nodules here. Hamartoma of that. Then the other features include, in neurofibromatosis 1 include optic nerve glioma, then multifocal choroid. These are eye manifestations. Multifocal choroidal nevus can be seen. Congenital glaucoma. Thick corneal nerves. Pulsating proptosis. These are the manifestations in neurofibromatosis type 1. Neurofibromatosis type 2, the manifestations are retinal hematomas and posterior subcapsular cataract. Retinal hematomas and PSC can be seen. In Sturge-Weber syndrome, that is in encephalophageal angiomatosis, diffuse choroidal hemangiomas here. This is a diffuse choroidal hemangioma here. Diffuse choroidal hemangiomas can be seen. In case of Sturge-Weber syndrome, diffuse choroidal hemangioma, telangiectasia of the conjunctival and scleral vessels. Conjunctival and episcleral vessels can be seen. Telangiectasia, leptomeningeal angiomas. Here leptomeningeal angiomas can be seen, and congenital glaucoma can also be seen. That is Sturge-Weber syndrome or encephalofacial angiomatosis. Next is hemangiomas of orbit. In hemangiomas of orbit, it can be there are two types like capillary and cavernous. Capillary hemangiomas and cavernous hemangiomas. Capillary hemangiomas are usually seen in young age, which is benign. Young age, and there will be a phase of growth followed by involution within 1 to 5 years. Initially there will be phase of growth, then it will involute on itself. Then on ultrasound we can see a poorly outlined lesion, irregular shape, then there will be high internal reflectivity, irregular acoustic structure, and variable sound attenuation. In case of cavernous hemangioma, it is usually seen, the proptosis you see it is axial, and it is usually seen in elderly patients. It is a well circumscribed lesion. Cavernous hemangioma, well circumscribed lesion, smooth counters will be there. Unlike capillary, which is irregular in shape, then here also there is high internal reflectivity in ultrasound. Okay, then it will be regular acoustic structure. Then there is poor vascular flow. Here there is typical this capillary hemangioma have this typical strawberry navel structure. And capillary hemangioma, there is another syndrome known as Kasabic-Merritt syndrome. It is also known as consumptive coagulopathy. Because the platelet gets trapped in the lesion, there is thrombocytopenia with associated cardiac failure. That is Kasabic-Merritt syndrome. Now metastasis in the eye. Next is metastasis in the eye. Most common part affected is choroid. Most common primary in men is lung, and most common primary in women is breast cancer. Now coming to evisceration and enucleation. Next is evisceration and enucleation. Evisceration is removal of the contents of the eyeball, two inner coats, like removal of contents of the eyeball, removal of contents of eyeball, leaving the sclera behind. We see the leaving the sclera behind. Enucleation is removal of eyeball with portion of optic nerve. Portion of optic nerve. In the evisceration, the most common indications are panophthalmitis, bleeding anterior staphyloma, expulsive choroidal hemorrhages. These are the indications in evisceration. Now enucleation, absolute indications are retinoblastoma and malignant melanoma. These are absolute indications. Relative indications are sympathetic ophthalmitis. These are the relative indications. Sympathetic ophthalmitis, endophthalmitis, phthisis bulbi, blind or disfigured eye like anterior or ciliary staphyloma. Then painful blind eye like absolute glaucoma, chronic iridocyclitis, or intraocular hemorrhages. These are relative indications. Now contraindication is panophthalmitis. Like if you touch the sclera, then this infection is going to the orbit. So this enucleation is a contraindication to panophthalmitis is a contraindication for enucleation.